thank the organizer for inviting me here to speak in this prestigious workshop. Can you confirm that you see my slides perfectly? Because I can't see the Zoom. So if somebody can note, it's
we do. Excellent, Nir.
Perfect. Okay, so I'm going to speak about Mycoplasma pneumonia, a new insight on a common pathogen. I've got a couple of conflict of interest which are not related to the topic over here. And what I would like to do within this talk is to go through very rapidly a few topics. First, a small introduction and history, and then some all the novel aspects, clinical aspects of Mycoplasma pneumonia, discuss briefly the severity of disease. And unfortunately, I didn't prepare much about the necrotizing pneumonia by Mycoplasma pneumonia, which exists, as Professor Collins just showed us. I will discuss some interesting features regards to epidemiology and touch briefly diagnostics and treatment. So Mycoplasma pneumonia, why it's important pathogen? Because it's one of the smallest free living bacteria that also cause disease. The genome size is extremely small. It's around 800 kilonucleotides with around 700 coding genes. And humans are the sole host for this pathogen. The other important feature of this pathogen that it doesn't have a cell wall, and thus no beta-lactam antibiotics will be effective against these pathogens. During the years, we had issues with regard to diagnostics. I'm going to touch that briefly in two instances. And an emerging issue is the resistance to macrolides, which is an important issue, but depending on time and location. And there's an issue of acariostates we're going to touch. So many refer to this publication in JAMA in 1938 by Hobart Raymond as the first paper dealing with Mycoplasma pneumonia. The point at that time that he was not able to isolate the pathogen and just describe this acute infection with what he called at that time atypical pneumonia or walking pneumonia. And years later, he told that he was regretting about this expression. The same year, two other giants in infectious diseases, Dingle and Finland from Boston, presented in the New England Journal of Medicine a couple of papers about pneumonia. And in this paper, the virus pneumonia 2, the primary atypical pneumonias of unknown etiology at that time, is probably the best clinical description of what just a few months later was thought to be what called the pneumonia by the Eton agent. And then in Science, indeed, by December 1938, Eton and colleagues from the Department of Public Health in Berkeley described a pathogen that passed through filtering, but was too small and that thus was perceived as a virus, but later on was found, only practically 20 years later, was found to be a real pathogen and known later to be Mycoplasma pneumonia. So what about the clinical presentation? The pediatric population, which is the theme for this workshop, is thought to be the reservoir for these pathogens. And it really depends on the location that you are residing, but in most of parts of the world, most of the infections occur during school age. One major exception for that is for a reason that we don't understand, is Scotland. In Scotland, for an unknown reason, most of the infected children will be in extremely young kids, probably preschoolers or younger than that. Plenty of outbreaks were reported in the literature, including military bases, mentally disabled institutions, and close communities. And in the 60s and early 70s, some vaccine studies were done. None of them achieved the clinical use. And I refer you to a review that we wrote about it, a meta-analysis. When you look on the clinical picture, you understand why there are many descriptions or thoughts about how Mycoplasma pneumonia respiratory syndrome should be look like. I use the analogy of people who are blind touching an elephant, each one of them looking at a different part of the elephant, and by that trying to understand what is the phenomena that we look at. But if we look on the clinical course, and this is a classical article published many years back, like almost 50 years or practically 50 years now, then there's the incubation period of this pathogen. And let me just put my laser on, and by that it will be easier. So there's an incubation period estimated to be 2 weeks, and then the clinical syndrome started with very mild symptoms, which include headache, malaise, a mild fever, sore throat, and a cough. And only a week to 10 days later, the major symptoms associated with pneumonia comes to reality with sputum production, dullness on physical exam, and rails on physical exam. And then you can see the infiltrate on a chest X-ray coming in, and then there's some resolution coming starting at the end of in the middle of the second week and later on. So depending on the time that you see your patient, will be related to the clinical picture that you see. And when you deal with admitted patient, then generally you get them just about here, because they have a week in the community, not responding to regular antibiotics, some sputum production, and pneumonia and physical exam. And that's the time that those cases may be referred to to admission when Mycoplasma pneumonia is not thought. Many other symptoms could be described based on this clinical presentation. Those may include persistent cough, dry cough when you're not in the middle week after the first week of symptoms, prolonged symptoms, fever, and other factors may be attributed in some of the cases include headaches, bullous laryngitis, throat involvement, rash, hepatitis, and in some cases, few cases, neurological phenomena. There's a question, what is or when should be asymptomatic presentation will occur, what age, whether it relates to prior immunity. And I will take for that an example from an unethical study published in 1961 in the PNAS. The researchers, which are giants of